Rahim. Assalamu alaikum. Very good afternoon. Welcome to you all to our online educational knee arthroscopy webinar. I hope all are well during this pandemic situation and hope for uh, well-being of your family. And pray to Allah, safe stay, keep you stay and healthy. Today's our title of the webinar is knee arthroscopic surgery. Where are we today? And welcome you to all our third, senior colleagues, junior colleagues, faculties and friends who like the arthroscopy surgery in Bangladesh and abroad. Welcome again to you all. Our first speaker, Dr. Javed Jahangir Tuin, Chittagong Medical College Hospital. He will talk on basics of knee arthroscopy. Dr. Javed Jahangir Tuin, please share your screen. I mentioned here the please participant keep your uh, camera and off and mute your speaker. Only speaker and moderator will on their camera and speaker. And our question and answer session will be at the last, and panelists will start our question and answer session.
Thank you, sir. Thank you, dear moderator, panelists, and my teachers and my colleagues, orthopedic surgeon and residents. I welcome you to all to today's webinar on knee arthroscopy. I will talk on basics of knee arthroscopy. Let's have a look to the learning objectives. You should know the arthroscope. What is this instrument and how to use it? How to assemble the different instrument and taking care of this instrument. The position of the patient, portal placement, and one most important thing is learning the triangulation technique. You also have to know and identify the intraarticular structure, sequence of exam, probing, and feeling through the extension of probe, and distinguish what is normal and abnormal. We all know arthroscope come from two words, the Greek arthros and scope. It literally means look within the joint. It simply have to look to the room through a keyhole without opening the doors. You know, it's different from open surgery. One term, what is called ambidexterity. It means that you have to proficient with your both hand. If you are right-handed surgeon, you have to proficient with your left hand. If you are left-handed surgeon, you must have your right hand also have to do the work. And what in open surgery, your eye, mind, and your movement and your instrument is same direction. But in arthroscopic surgery, it is in the opposite direction. And precise location of the portal and creation of portal is very important, and access to the posterior structure, particularly when repairing meniscal tear or meniscal root repair, is sometimes difficult. You need to know the intra-articular anatomy and pathology and correlate what you are seeing with your monitor and it's your mental viewing. First reported arthroscopy is Nordentov, a Danish surgeon, and the term arthroscopy is coined by Hans Christian Jacobus, who is a Swedish orthopedic surgeon. But the modern arthroscope is designed by Kenji Takagi, all know. But it is the Masaki Watanabe who is regarded as the father of modern arthroscope. And his design is adopted worldwide. He was the first to truly use the arthroscope for therapeutic purpose. The first recorded partial meniscectomy is 4th of 1962. The cold fiber optic light source was introduced in around 70s. McGidney and Johnson were among the first to introduce television camera in the arthroscopic system. So now come, you have to prep and dep. You see chlorohexidine wash, which are called primary wash. And after primary wash, you have to soak the whole operative area with povidone iodine. And after povidone iodine, soaked with povidone iodine, you can wrap the limb with a sterile drape towel. Now come, let's have a look to the basic instrument kit. There are lots of different types of varieties of arthroscope. Most commonly used arthroscope are 30° and 70°. There are also 45° and 90° arthroscope. Fiber optic cables, light source, television camera, and one important instrument is motorized shaving system. There are adjunct like electrosurgical laser and radiosurgical instrument. And accessory instrument which are essential is probe, basket forceps, grasping forceps, arthroscopic knives, and some sophisticated and PCL set. You can autoclave your instrument holding just keeping this. It's my instrument. I usually use this cotton block for keeping my instrument and autoclaving also. Now come, it's for junior and the residents. You have to a arthroscopic card where all the console and monitor was placed. In this picture, you see this is light source, this is camera with cable, and this is shaver handpiece, shaver handpiece. At this point, the shaver is attached. Now come to the arthroscope. This is 30° arthroscope from Lindbeck Conmatec. It is about BU angle about 4 millimeter. It is diameter is 4 millimeter and BU angle is about 115°. This is arthroscopic sheath and this is 5.5 millimeter usually. 6 millimeter arthroscope with incorporated irrigation system is much better. This is probe. Two types of probe I have shown here. Usual diameter is 4 millimeter around, and these are some basket forceps. Some are straight, some are right angle or left angle. There are other some instrument. This is, here you see tendon stripper, sizer, drill bit, SEL jig, and a screwdriver. And you have a look to other the screw, bio screw or titanium screw and the suture peg. Now have a look. Now let's have a look to the sterilization. You can sterilize your instrument with autoclave, plasma sterilizer, ethylene oxide, Sidex, formalin vapor. In previously, all our arthroscopic instrument is usually sterilized with Sidex, but more and more all instrument now can be autoclavable. I personally autoclave the all instrument except shaver handpiece. But plasma sterilization is very good. If you use Sidex, it's okay, but you have to uh, keep it isolated. When you using Sidex, you must keep isolated it. You cannot use it with other combination like urological or gastrointestinal surgery. Formalin vapor, it was used previously, but it was not used now, and it was discard, discarded maybe. So you can do in two position usually knee arthroscopy, in supine position with the band knee. You have to flex your knee joint in 120-degree when you femoral tunnel drilling, during femoral tunnel drilling. And another is hand is knee is hanging at the end of the table. And two important adjunct is tourniquet and lateral leg post. You can use tourniquet for increased visibility, but more and more arthroscopic surgeons are doing arthroscopy without tourniquet in nowadays. One important adjunct is your lateral thigh post. It's very important when viewing the posteromedial side of the joint for medial meniscus, posterior horn repair, or doing something at the root level. You have to put a valgus thrust to opening the medial side of that joint. Similarly, if you have to, you can put a post in the medial side of the thigh also, if possible. So have a look to this video. It is the supine position, and you can change this to now lateral position, putting a sandbag just behind, just below the thigh and side of the joint. And now examination under anesthesia, most important part is examination under anesthesia. You have to check Lachman test, anterior drawer test. You have to check for medial and lateral collateral ligament, and also pivot shift test. So examination under anesthesia, it's include whether there is any effusion, range of motion, mobility, patellar mobility. And for cruciate ligament, the anterior drawer, posterior drawer, Lachman test, collateral ligament, and don't forget about the dial test for posterolateral instability. And one important test which very difficult to demonstrate without anesthesia is pivot shift test. You must check for this after anesthesia. So let's have a look. Drawer test and is grade 3 Lachman with no endpoint. You also have to look for pivot shift test. This picture very nicely demonstrates pivot shift test. Now come to the portal placement. It's very important in arthroscopic surgery. Two most important, there are lots of portal. Two most important portal is anterolateral portal and anteromedial portal. Anterolateral portal is just lateral to the patellar tendon, 1 centimeter above the joint line, the soft space. Anteromedial portal is a bit medial, 1 centimeter medial to the medial margin of the patellar tendon. And usually for knee surgery in ACL reconstruction, we usually prefer anteromedial portal. Anteromedial portal is the main portal, main workhorse of arthroscopic surgeon. So you have to create this portal. You have to create your portal very precisely and use blunt trocar to avoid injury to the intra-articular structure, anterior cruciate ligament or cartilage. The trocar should be aimed towards the intercondylar notch, as because there is a much space here. Now, next sequence is probing first, and now triangulation. You have to take care of when creating a portal. If it's very near to joint line, the lateral meniscus anterior horn can be injured. Sometimes the difficulty in maneuvering the scoop when it's very close to the joint line. If it is much superior to the joint line, it's prevent viewing the posterior structure. If it's very immediate adjacent to the patellar tendon, the fat pad impair your visibility, and maneuvering SQ is sometimes very difficult when it's very near to the fat pad. You may have encountered some problem making portal in obese patient, osteoarthritic patient with osteophyte, some intra-articular adhesion, and knee with flexion deformity, if patient having locked meniscus and big loose body within the femoral notch. Let's have a look to the irrigation fluid. Usually we use normal saline, but it was said that lactated ringer solution, that means Hartmann solution, is much better. If you want to use intra-articular deep diathermy, you have to use glycine. For maintaining joint pressure, gravity or arthroscopic pump used. Usually if the fluid pressure is 50 to 60 millimeter of mercury to maintain the clear view. And it is increased 80 millimeter of mercury during femoral tunnel drilling. Usually 5 liter bag, 5 liter bag is much better, and Y connector which is used in urological surgery is much better. But you can use also blood set and saline set, you can also, and usually the bag is placed 3 to 4 feet above the level of the joint to create approximately 66 to 88 millimeter of mercury pressure. Usually 60 to 80 millimeter of mercury is sufficient for knee joint. For shoulder and elbow joint is much less. For a successful arthroscopy, you should able to insert the scope effortlessly. You have able to see, you should able to orient, able to reach the lesion with instrument, and able to differentiate normal and abnormal, and able to do corrective surgery. And what is the good sequence? Examination under anesthesia, accurate portal placement, gentle insertion of the scoop and instrument, systemic examination of the whole joint, probing, look from to portal when it needs, and maneuvering scoop, manipulate knee, which is very much important. You see in this video, we're going to do a ACL reconstruction using, you have to first connect it all your wire with your scope. All your scope, you have to attach with console. Now our arthroscope is connected to the camera head piece. I just have a take a few times with this video. Now white balance, you have checked for white balance. So white balance is okay. Making portal, introducing portal, negotiate, and in the suprapatellar pouch, fluid, irrigation fluid is connected. Now within the suprapatellar pouch, you start your examination and diagnostic workup. In the last, you see anteromedial pores created, and you have to look for triangulation from outside. So what is triangulation? This is the art of bringing two or more instrument into the field of vision. Just start from familiar and wide space like suprapatellar pouch or femoral notch. You sometimes, in where there is the adhesion, you might not see the instrument. In that case, you have to feel the instrument touching the scoop and always look from outside. It needs psychomotor skill, visuospatial learning. You can learn with arthroscopic simulator and touch and follow the scoop, side to side sweeping, rotation of camera when the variable degree of camera if used. So another important is switching instrument. You see, so triangulation is very important, and you have to check externally and internally and sequentially hold through the joint sequentially, otherwise you will miss. So there are lots of pattern. You can start with suprapatellar pouch, lateral girder, medial compartment, intercondylar notch, lateral compartment, posteromedial compartment, posterolateral compartment. There are more. There are many more sequence. You can follow one. And one important tips is switching portal is very important. When you are difficulty being from one port, you have to switch the instrument from another port. Now, take a look for indication or use. Usually for meniscal resection or meniscal repair, removal of loose body, ACL, PCL reconstruction. In septic arthritis or any other arthropathy, you can use the labas. For synovectomy, in osteoarthritis, rheumatoid arthritis, pigmented bilionodular synovitis, synovial chondromatosis, some cartilage problem, and lateral retinacular release in lateral patellar pressure or overload syndrome, and some less indicated arthroscopy is in before unicompartmental knee replacement or high tibial osteotomy and arthroscopic assisted fixation of the tibial plateau fracture. Let's have a look what could be wrong. And sometimes there is a blackout when no image is seen. Light sources, if that occur, you have to check for light sources turn off. If there is any power supply to the monitor interrupted or not, video camera lens is clear or not, monitor input might be hampered, or a plug, wrong format, and malfunctioning video. If there is a blurred image, camera might be not focused, flow might be less, or there is a empty saline bag, or sometimes there is improper suction. Joint looks strange when non-anatomic position of the screw. Red out, it's occur, you can't see anything, there only the red. This is in case of bleeding or improper tourniquet, or if you put a Bureau suction. Or sometimes if your shaver is not functioning properly, you have to check it out. So take home message, make appropriate working portal first time. It's a very important thing. If you make a wrong portal, your whole operation will be jeopardized. So if you made a mistake making portal, you just make portal which are appropriate. Do not hesitate to make accessory portal when necessary. The two important terms, ambidexterity and triangulation, you must have to learn. And do not hesitate to switch portal, and you need patience. In first 100 arthroscopic, you just need how to triangulate, and next 100 arthroscopy, you learn something to do. Thank you very much.
Thank you, Dr. Tuhit, for your elaboration on the arthroscopic tower instrument and patient examination under anesthesia and triangulation. And thanks for details showing the basics of arthroscopy to our viewers, participants, and panelists. Thank you. Please establish screen. Our next speaker, me myself, my topic is articular cartilage injury, the hidden knee lesion. I share my screen. Yeah. Can I see my screen?
Yes, sir.
Hello. Yeah, yeah. Thank you. Assalamu alaikum. Very good afternoon, dear friends, colleagues, teachers, and participants, and panelists, as well as my speakers. We are all doing regularly arthroscopy, and by which we are doing ACL, PCL, meniscus repair or resection. But there is some hidden lesion of the knee which causes your reconstructive procedure fail until now unless you address this lesion. One of the aim is articular cartilage injury. Everybody know there are various role of articular cartilage in which physiological role of articular cartilage, that means it minimizes the stresses on underlying bone, it reduces the friction on weight bearing surface. Please, who are dear viewers, please stop your mute your speaker. And it transmits the loads to the underlying bone, and it is articular cartilage always it is critical in proper joint function. Because so you can see this slide, there is whole clearly articular cartilage of the distal femur as well as knee, but there is some defect. And here also you cannot visualize the articular cartilage. It represents the only space, that is radiolucent space in the articular cartilage. There are various factors regularly cause articular cartilage injury. Among them, trauma, blunt impact, polytrauma, traumatic patellar dislocation, and repeated microtrauma, which causes articular cartilage damage around the knee, mostly petrofemoral joint, and axial malalignment of the knee. That is very important. That is varus, valgus deformity or hyperextension or flexion deformity. This causes the articular cartilage, as well as total or partial meniscectomy, instability of the knee, ACL, PCL injury, and other collateral injury causes articular cartilage damage, and osteochondritis dissecans. One of the important factor for injury of the articular cartilage osteoarthritis, rheumatoid arthritis also cause articular cartilage. Other and more genetically determined factor also causes articular cartilage damage, as well as high BMI index, obesity, and cartilage tumor causes regularly articular cartilage damage, which causes injury of knee. There are various varieties of classification of articular cartilage injury. Among them, outer bridge is most perfect one, which is regularly used in knee arthroscopic procedure, most of the arthroscopic surgeon. In this classification, we categorize the articular cartilage normal, that is grade 0, that is normal articular cartilage, and grade 2, that is softening, blistering, or swelling of the articular cartilage, that is grade 1. And grade 2, that is partial thickness of articular cartilage injury, in which there is fissure, clefts, and it is usually less than 1 centimeter in diameter. And grade 3, here there is full thickness articular cartilage damage. There are fissures and clefts up to the subchondral bone. Usually it's diameter more than 1 centimeter. And grade 4, it is exposed to subchondral bone. You can see there is articular whole thickness articular damage and subchondral bone that is exposed. Examination Physical examination should focus on the following pathologies, which are the very important for the in relation to the articular cartilage injury or damage, either which is traumatic or degenerative or repeated microtrauma. Among them, malalignment, whereas valgus deformity, limited range of motion, and effusion, and may patient come to us with instability as well as meniscus integrity should be assessed. Sometimes patients come to us with clicking, grinding, or any other pathological sounds, and casing, also locking, and maltacting or tilting of the patella. It is all physical examination, but all symptom sign patient come to us with articular cartilage injury patient. X-ray is a very important for the assessment of articular cartilage defect or osteochondritis dissecans. You can see this X-ray. It's a regular anteroposterior view X-ray, and when it is weight bearing, you can see that it is reduced joint space. That means no medial articular cartilage in the medially, and there is no space in the lateral joint line. And in this figure, there is, you can see that is lateral view X-ray. That is the high rise of patella. That is patella alta. Each type of variety, while kneeling, squatting, prolonged sitting, or prolonged stair climbing causes this type of variety. Also, this type of variety causes articular cartilage damage. When the patella is low down, that is baha or infera. And among the very important when we do it to detect a articular cartilage injury patient, we must do the scanogram from the hip pelvis to up to the ankle. This is very important. So the all joint alignment to assess the articular cartilage injury for a patient. And also some view of the X-ray view are very important for assess the articular cartilage injury. In this view, you can see that is Martian view. In this Martian view, there is the articular cartilage detect can be from the lateral undersurface of the patella, mostly lateral surface. In case of tunnel view, in case say there is posterior part of the distal femoral condyle, posterior part of the detection of the osteochondral defect. You can see the detached osteochondral fracture within the tunnel of the nose of the knee joint, and it can be easily detected by tunnel view of the X-ray. And this is also in weight bearing 30-degree flexion of the knee. This causes the also the medial posteromedial aspect of the lateral condyle as a posterolateral aspect of the medial condyle to detect any articular cartilage damage. You can see it is weight bearing 30-degree flexion. A posterior anterior view. Easily you can detect the articular cartilage by seeing a simple X-ray. That is posterior anterior view. An MRI and can easily the size, depth, breadth of the articular cartilage damage easily detected osteochondral injury. In this coronal view, we see that that is the other cartilage injury. In case medial condyle, this is lateral condyle, this is medial condyle. In case of axial view, you can see the undersurface of the patellar osteochondral defect. This is, and this is sagittal view. We can see that is lateral condyle articular cartilage defect. It can easily measure by seen by MRI where the size, shape, depth, and weight of the articular cartilage injury. And why we go for treatment of the articular cartilage, and which is the causes hidden knee lesion, and otherwise you treat it to all other procedure would not elicit the full result. So our goal should be maintenance of the integrity of the load-bearing surface, obtain a full range of motion, regain pain-free motion, and inhibit the further cartilage degeneration. This is our goal to treat the articular cartilage injury. There are numerous variety of treatment for the articular cartilage injury, but in case of our scenario, we do only limited. But we should know all the name and procedure of the. But in our perspective, we do only limited. Yes. In this case, the first step of the treatment of the articular cartilage injury, that is arthroscopic lavage and debridement. Please view removal of debris and inflammatory mediator. Please, dear participant or viewer, you stop, you mute your speaker mic, and to it can create a noise to us. And in case of abrasion and arthroplasty, first arthroscopic level development we can do it easily remove the small type of articular cartilage and we never go to the cancellous bone. Only we do the subchondral cortical bone. If we do further injury or abrasion of the arthroscopically shaver or word to cancellous bone, there is overgrowth of bone, which causes again further joint pain or interruption of joint motion. So be careful about the abrasion arthroplasty. And other variety that is microfracture, we are commonly doing it. We can easily debride the articular cartilage to a stable uh, rim, that is margin should be vertical one, and subchondral bone penetration through the calcified cartilage layer. Calcified cartilage layer is just above the subchondral bone or deep to the hyaline cartilage. We should remove it, and 3 to 4 perforation per square centimeter. Initially, we start at the peripheral microfracture, then gradually towards the center, and always keep it up to 6 millimeter, 2 to 6 millimeter apart from one penetration to other penetration, and this leads to result in fibrocartilage repair. So you can see a small video for my arthroscopic microfracture. Also, you can do it. It may be now it is called it is nano fracture or drill, power drill by power peak. Easily you can see it is initial, that is it is a type of medial femoral condyle of trochlea, that is it is about grade 4, that is acute subchondral bone exposed initially by shaver or curate. You created the margin a vertical one and remove all dead and devitalized tissue as well as the flaps of cartilage, and then initiate our micro puncture by the owl. It may be wire 1.8 millimeter wire or 2 millimeter wire, or the power deal 1.5 millimeter deal, or it may be owl. In case of different location, you use different variety of that is uh, 15 degree or 45 degree or 90 degree our angle out. In case of Petla, I always use 90-degree angle out. You can see the variety after the percussion we start, then gradually change toward the center. You can see there is up to this proportion up to 6 to 9 millimeter, up to the just touch the cancellous bone, no more the within the cancellous bone, just subchondral bone penetration. This penetration when complete, then we release the tourniquet to ingression of the bone marrow content. This bone marrow content you can see in this video later on, ingression of the bone marrow content, which leads to stimulation. So showing a video and sorry, it is in content. So ultimately, this leads to ingression of bone marrow contents, which leading ultimately formation of fibrocartilage, and which the replacement of the hyaline cartilage, and which the but its durability and the mechanical properties less. So I go next slide. It takes two more time. Details the narrow egressing through the when tourniquet release from the through the hole. Yes, bone marrow content egressing. So I go next. And other variety of osteochondral autograft transplant. It is osteochondral. It is also called mosaic variety, mosaic plastic. Some non-weight bearing or non-contact area, the donor side, and harvesting towards the defected side, and creating some tool and which does feed the from grafting from the donor side to the recipient side. You can see that it is a defected side, and this was the bone plug. This bone plug after harvesting this kit. That is, it is osteochondral autograft transplant, or it may be mosaic plastic. Usually, full thickness grade 4 lesion used, wide bearing surface of the femoral condyle, while circumference lesion sharp instrument tool, and it is less than 2 centimeter diameter lesion, and it is always in young active patient. And another autologous chondrocyte implant is ACI. Here from initial stage, there is arthroscopically removal of chondrocyte from the lateral aspect of the medial condyle or intercondylar notch. Then cartilage cells are calcified outside in vitro, outside after 2 to 4 weeks. Then again it is implanted in the cartilage defect, and it was sealed by the fibrin glue, sometimes porcine collagen membrane or periosteal sleeve. This is in our perspective, we do not. This is here it is allograft transfer when there is large osteoarticular defect. Then the cadaveric from the frozen cadaveric allograft we are transplanted here. And other than this, we have some other treatment modalities and associated conditions should can follow. And thermal chondroplasty, it also we do it with the radiofrequency ablation. We can seal the articular cartilage defect, and marrow augmentation scaffold stimulation, and osteotomy varus valgus, and sometimes tuberosity osteotomy to correction of the intermedialization or distalization in case of extensor mechanism malalignment, which is articular cartilage injury. You can see that is mass, that is defect, that is microfracture, and bone marrow and skipping, and the application of the scaffold stimulation, uh, that is stimulation, that is PRP, or and then mixer with it is attached with the fibrin plot or artificial commercially available fibrin group. And one my patient who is come to me with repeated pain, that is petrofemoral pain. He was from his history, he was operated 7 to 8 years before for recurrent patellar dislocation, and he was treated as a medial plication lateral release as well as Madigan procedure. And I seeing the Marcenta X-ray, that is patellar osteochondral defect, and I decide him to do arthroscopic patellar microfracture and reconstruction of the MPFL and uh, medialization of the tibal tuberosity for his recurrent patellar dislocation with osteochondral defect. And this patient he regained his full range of motion, but due to this situation, I cannot come to my chamber and to take this video. He is happy with this procedure. He is another patient. He is also in case of CT scan, 3D CT scan, that is osteochondral defect, and also fragment, and this is MRI. This is osteochondral defect. Just arthroscopically this was defect, and this fragment was loose. I remove it, and I just microfracture the detected area after shaving and creating a vertical margin. And by radio frequency ablation, I do uh, the thermal arthroplasty and the microfracture, and this procedure is done. This procedure is happy. And this patient was a student of madrasa, and he was always reading Quran in the position with the prayer position. And this is a healthy girl, healthy young boy, and he come to my with the symptoms of knee pain, and I identified that he is suffering from condyle injury. He now is happy with this procedure. So in my conclusion, articular cartilage does not repair itself. Numerous treatments with varying result, and most treatment unpredictable in the long run due to articular cartilage inability to reproduce hyaline cartilage, and all resurfacing procedure work better or last longer when proper alignment and stability is restored. Thank you, thank you, thank you for hearing. So, thanks everyone. Our next speaker is Dr. Uh, Muhammad Bakibullah. His topic is tunnel placement is crucial for cruciate ligament reconstruction. Please, Mr. Dr. Bakibullah.
Thank you, Jangir bhai. I think I am audible to everybody.
Yes, audible.
So, Assalamu alaikum.
Please,
so tunnel placement in ACL reconstruction, we all know about it. We are now preparing the anatomical ACL reconstruction. And for the anatomical ACL reconstruction, what is the difference of the transtibial ACL reconstruction, tunnel placement in the femur, and present anatomical tunnel placement? We all know about this. But we think that to have a proper tunnel placement, we should know some tidbits. If we follow this tidbits, our tunnel will be more better in position, and that will give us a better outcome. So that's why I want to presenting this paper to you to see the anterior cruciate ligament anatomical perspective. Already it is discussed again and again. We know it is a double bundle structure, and its interarticularly it is about 50 millimeters, and it's about 7 to 17 millimeter in width. Everything is there. You see, this is an anatomical structure in a cadaver, and the placement of this ACL usually from tibia to femur, and it's usually attached in behind the behind the residence ridge. This residence ridge is very important in arthroscopically because all the tunnel should place in the femur in this area. Just behind the lateral intercondylar ridge, usually known as residence ridge. And if we place the tunnel in this area, this will make the anatomical tunnel, and this will give us a better result. You see, we know that the ACL is a double bundle structure, but we prefer the single bundle reconstruction. And why single bundle we prefer? Because single bundle and double bundle is a big debate, and usually we see that the single bundle gives the same biomechanical stability as the double bundle, and so we prefer the single bundle. Usually, in single bundle, we make a tunnel in the tibia and another tunnel in the femur. But in double bundle, it makes a double tunnel in the femur and in the tibia. And this double tunnel sometimes makes the double trouble in double bundle reconstruction. So we prefer the usually single bundle. And many disadvantages of the double bundle is there, and usually long operative time, tumoral connection, chondrolysis, maybe in case of double bundle, and it is more technically demanding. So our aim is to make a single bundle in both bones. And you see, the only for the double bundle recommendation is only for the that sportsmen. They are pivoting is very much demanding in that in those persons who usually prefer the double bundle, but now we are discussing about the single bundle reconstruction. So both tunnel we should place in the anatomical position. Anatomical placing, the anatomical placement of the tunnel that gives us the improved rotational stability and as well as anti-posterior stability. And what should we do in case of skeletally immature patient? And somebody shows that there is, if we place the tunnel in transepithelial or transfacial placement of the tunnel that does not make any angular deformity or linear deformity in case of immature patient. So now we want to discuss about the tunnel. Tunnel drilled independently. If we make the tunnel independently in the femur and in the tibia, it allows the more oblique graft placement. And this oblique orientation of the graft is very much important to prevent the pivot shift and to make the to give the rotational stability to the knee. And tunnel placement is whether it is high or low. The high means whether it is in 1 o'clock or 11 o'clock position, or in low in 2 o'clock position or 10 o'clock position. So we prefer the low tunnel because if this low tunnel placement gives us a better intraoperative internal rotational stability. So for the femoral tunnel, we are able to make the anatomical tunnel in the femur. This is very important to place the portal in an appropriate position. So usually we anterolateral portal we use for the visualization. Dr. Jahangir already discussed about this, and medial portal is placed for the working portal, and for the placement of the screw in an anatomical low in 10 o'clock or 2 o'clock position, we should use this anteromedial accessory medial portal. And this portal helps us to make a good transverse and low position tunnel in the femur. So you see, we should place not in the 11 o'clock. Previously, when we make the transtibial portal in the femur, that will place the 11 o'clock and it is quite high. We should make the tunnel in between the 10 or 9 o'clock. If we make the tunnel in the 10 and 9 o'clock position, that will give more anatomical position So we can make it by inside out. Usually we use this one inside out technique, and outside it we can make. And outside in retro drilling we can make, and shaft tubular drilling it is almost obsolete now. So transportal. You see, to have a transportal, usually we use this one, accessory anteromedial portal for transportal femoral tunnel placement. And for this tunnel placement in the transportal tunnel placement, we should place the knee more near about 120-degree flexion should be placed in 120-degree, and medial portal is as low as possible we should place. And what are the difficulties we may face in the transportal femoral tunnel placement? The difficulty may be the injury to the cartilage and short tunnel length and limited visualization in transportal methods. But we can minimize it by many ways. So you see, usually in arthroscopy, usually we find that this on the lateral medial surface of the lateral condyle, and most of the time it is empty. We can understand that the ACL is evolved from this femoral side, and this is the side of the placement of the, and this one is this place is the place for the tunnel placement, usually anatomical footprint of the ACL, and this is the AM bundle and PL bundle placement. Usually we prefer this place for the center bridge in the techno position for the placement of the femoral tunnel. And before placing the femoral accessory medial portal, you see this one the medial portal, and we should make another accessory medial portal here. And before placing the portal, we should charge it by placing a needle, usually spinal needle. And you see, usually that needle should be just touching the condyle. If just anterior to the condyle, if you place the portal, that will help to make the portal more transverse and more posterior. And we should be above the, and making the portal, we should make the during making the accessory portal, we should be cautious that blade surface should be away from the condyle. But if it is facing the condyle, it may injure the cartilage. Again, after making the portal, we should introduce some guide for the femoral guide, usually bull-size guide, and that show us the proper placement. And with this guide, we can drill first by a wire, and after that, we should check the integrity of the wall, anterior, posterior, and integrity of the tunnel wall. We should check. At least 2 mm of the posterior rim of the femoral tunnel should be preserved. If we fail to preserve the posterior wall at least 2 mm, it may blow out. So to prevent the blowout of the posterior wall, we should preserve the at least 2 mm of the posterior wall. And what about the tibial tunnel? Tibial tunnel, you see, it is less complex than the femoral tunnel. We can place the tibial tunnel 9 mm posterior to the intermeniscal ligament, and 78 mm from the PCL, and nearly 6 mm anterior to the projected line from the apex of the medial tibial inguinum. And that is the anatomical center of the ACL. And usually outside entry, we should think that the outside entry 4 cm from the tibial joint line and 2 cm medial to the tibial tubercle. It should be outside entry of the tibial tunnel. The center of the tibial tunnel and placement of the tibial cheek and drilling. And after that, the tibial tunnel malposition, if we go for the tibial tunnel malposition, if the tibial tunnel is more anterior, then anterior knee pain, roof impingement, maybe there. If it is tibial tendon is a bit posterior, it may cause the PCL impingement, and you can avoid these all things, all the complication of the tibial tunnel placement by placing it in proper place. And femoral tunnel malposition, it may also give some trouble if it is anteriorly, more anterior, and this anterior placement may cause the fixation failure, and flexion, inflection may be tight if the tunnel is a bit anterior, and if it is a posterior, it may cause the blowout, posterior blowout. So if it is high up, then it may fail to give the rotational stability. So femoral tunnel should be in place. So in summary, we can say the rotational stability is important to reduce the future osteoarthritis, and to have a proper tunnel in the femur, and accessory and remedial portal placement is very important, and its low placement of the femoral tunnel is very important. Thank you all for the question here.
Thank you. Thank you, Dr. Bakibilla, for your tunnel placement. It is very important for accurate tunnel placement regarding the anteroposterior translation as well as rotation of the ACL reconstruction. Thank you. Thank you for excellent presentation. Our next speaker, Dr. Alamgir Adil Samdani, he will talk on ACL reconstruction outcome comparison in early and late presentation. Please, Dr. Samdani, share your screen.
Thank you, Jahangir bhai. Thank you, organizer, for arranging. Can everyone see my slides?
No, no.
Not yet?
Dr. Bakibilla, stop your sharing screen. Please stop your screen sharing.
I have already stopped it.
Can you?
No, no.
No.
না স্যার এখনো দেখা যাচ্ছে না স্যার এখন আসতেছে স্যার
আসতেছে?
আসতেছে স্যার
Yes,
একটু ওয়েট করুন
yes, এখন দেখা যাচ্ছে।
Okay. So basically, those who
স্যার এখনো আসে নাই
না, এখনো শেয়ার হয় না, শেয়ার হচ্ছে।
is it clear now?
No, no, just slowly sharing.
স্যার আপনি স্টপ শেয়ার করে আবার শেয়ার করেন
হ্যাঁ, stop share করে
Stop share.
Yes.
চলে আসছে স্যার আর দরকার নেই
Yes.
এখন চলে আসছে।
আসছে?
হ্যাঁ স্যার ফুল স্ক্রিন দিন হয়ে গেছে স্যার এখন প্রেজেন্ট করেন
Okay. So thanks to organizer, thanks to panelists, thanks to speaker and all the parts to basically join in this kind of mission. We are in a speed breaker scenario with the corona, still because of our integrity, because we are doctor, we have an oath to do our duty. We are carrying on with our academic activities, which is nice. May Allah let us carry on with this kind of activities. So those who are dealing with knee problem, we know the knee is a very amazing joint in the body, and I think everyone can imagine what will come up in future, that the knee is so much in the futuristic joint. You can say that nobody knows what will come in near future. Today I'm going to talk about one of my experience. This is basically involve all the orthopedic surgeons who do with arthroscopy in Sylhet region, including our Baki Bhai, because I have done many arthroscopy with Baki Billa. So let me start. So this is considered one of the commonest sports injury worldwide. And as you can see, 1 in 3,000 people in USA affected by this kind of injury. And which brings up to 150,000 of ACL tear in 1 year time. As Dr. Javed Jahangir nicely said, that the first ACL was repaired in 1900 by somebody known as Battle. And you can imagine when we started playing with our ACL reconstruction, treatment is widely accepted because whatever we do, I do, somebody else is doing in UK, USA, nobody has any dispute on it. Maybe we can argue on it, we can make a discussion on it, but we actually accept it. So this is basically whatever we do, still the knee or ACL surgery, anything is still on evolution. Still there is no end to it. This is what I'm trying to say. So my exposure basically started from 2012 when I joined Northeast Medical College. At that time, we did not have any arthroscopic machine. So I started doing open procedure. And right now in Sylhet, only in Sylhet, we have about 5 to 6 arthroscopic machine. So since then, I have done about 180 ACL. Among them, about 50 of them was open procedure. I was doing open procedure alone, now arthroscopically all of them. In my studies, I have found most of the injuries happen between 20 to 30 years of age when they're basically very active in their lifestyle and involved in sports activity. The age was ranges from 15 to up to 50 years. The people who with ACL injury averagely presented to me in 2 years' time. This is basically my finding. It may have different in other people's mind, which is also a basically delayed presentation, as you can understand. And it ranges from 4 weeks to 8 years, which means that people having an ACL injury comes to me maybe within 4 weeks, or in some cases I have seen people coming to me after 8 years of injury. Basically, the time gap between initial injury and diagnosis in the case in terms of prognosis is very significant. We divided our people into 2 groups. The group A, basically the people who came to us within 6 months following injury, and the group B when the people came up to us 6 months after injury. In group A, we had only 75 patients, and group B, we have 105 patients. So you can see again, people coming after 6 months is more than people coming within 6 months. We did a prognostic chart during our follow-up time, and we recorded it accordingly. So this is a prognostic chart, as we all know who does arthroscopy, how we follow them. But we designed it from our perspective in Sylhet, or as you can see that we don't have enough follow-up facilities or we don't have enough physio facilities. So we developed this kind of grading system. We all know after ACL surgery, it takes about few weeks before the patient can walk comfortably. People who can walk comfortably on flat, those are happened in 4 to 6 weeks time. We have seen these are the people who are in group A, basically. People who presented to us within 6 months of ACL surgery, and we operated on them, reported in follow-up cases accordingly. They can climb their stairs within 6 to 8 weeks comfortably. They can pedal on a cycle within 8 to 10 weeks. They can also walk on uneven surfaces like ups and downs within 10 to 12 weeks. And they can run comfortably in 12 to 14 weeks. These are the people in group A. So what happens to people in group B? So when we look into our chart that how they are doing in people in the group B who presented to us 6 months after injury. On an average, it took about 2 to 3 weeks longer in each step to cross every step. What I have shown in previous surgery, it took about 2 to 3 weeks in average. Sometimes it took 4 to 5 weeks, but basically I have shown in the average picture to reach their targets. But successfully, both of them basically rehabilitated the whole rehab protocol completely. So there are basically few factors I have basically outlined, as you all know, but these are the factors again causing them to come us too late. And I'm going to explain it to you. The pain is a common symptoms that brings the patient to us. It is very subjective. So in our country, people runs around here and there with knee problem before they goes to right person. By this time, pain subsided, as we all know. Normally it subsided. The patient more thinks that I may have gone better, so I should go for any treatment. Second, instability. Instability is basically very important perceptions. I have seen very can explain it to us, unlike other places. They cannot tell you about this. So it's very difficult for them to find out what instability is. As soon as they find out what instability is, they basically change their lifestyle. All these things are basically, see, they are delaying their presentation to a surgeon or an orthopedician. Subsequently, when they change their lifestyle, the limb become weak. Ultimately, they have to change their lifestyle with a weak limb, and as well as they get muscle wasting. These are the things that brings the patient to us. These are the things that also brings the patient late to us. Am I clear making you understand this? The symptoms basically is very subjective to our patient, and they also argue on this, that these are the things as basically stopping us from coming to you. We all know ACL can be an isolated injury. It can also come with meniscus injury. It can also come with ligament injury. It can also come with chondral injury, which Jahangir Bhai has shown us nicely. We all know about a chronic ACL injury. If an ACL comes to you as an isolated injury in acute cases and which is not dealt in time, it may turn into a chronic ACL injury. And most of the time in all the journals says in chronic ACL injury, you will end up finding a meniscal tear or a chondral damage or subsequently muscle wasting, and eventually it changes the gait of the patient. There is a picture showing how an ACL rupture can affect your muscle. Look at the right thigh. The girth of the muscle is so much narrowed from the girth of the unaffected side. Again, another picture of a muscle wasting. If you look at this picture on a white socks, which is his left leg, the calf muscle is so much wasted than the calf muscle on the right side. This is another findings we have seen, that where it becomes very difficult for the patient who goes into stiffness or wasting because of the late presentation. After the operation, you cannot basically get them into moving. You cannot flex their knee completely because of their weak muscle. And the knee also, they may also come with a stiff knee, which is very difficult to rehabilitate after the operation. So there's a picture of a stiffness on the right side, the picture of a muscle wasting. So we come up with a recommendation. This study is still going on. Basically, I'm carrying on doing it. There are a lot many stuff to evaluate on it, but we have come up with a recommendation just only for this today's webinar. We need a proper pre-op assessment, looking into this patient's muscle bulk, muscle strength, and range of motion. If needed, basically, we need to go for a pre-op physiotherapy to increase the muscle strength and increase the motion. We also need to remember that doing a surgery too early is maybe also difficult for this patient after the operation. There's a term we all know about second hit in case major trauma. This can also happen because in my study I have found about 30 cases who have come up with bone bruising. So you can understand a bone bruising is not a fracture, but it also damages your bone So after a bone bruising, if you don't let the bone to heal up and you do an OCL surgery, this becomes a second hit, and basically patient remains in pain for longer time than you can expect. So too early surgery is also very difficult. Next is post-op physio need to be more than usual period. So if you find a patient who is presenting to you late than you expected, so you may need to put them on physiotherapy or rehab protocol for more than usual time. That's all about it. Thank you all. Thank you very much.
Thank you, Dr. Samdani, for your crystal clear presentation
Thank you all.
regarding the early and late presentation of the patient with ACL injury. Thank you. Thank you, Dr. Samdani.
Thank you.
Our last presenter, not the least, Dr. A.M. Fariduddin Ahmed. He will talk on harvesting hamstring tendon. Please, Dr. Fariduddin Ahmed. Dr. Farid, can you hear me? Farid.
Yeah, assalamu alaikum.
Alaikum assalam. Welcome you to our webinar. Please present your talk.
Let স্ক্রিন দেখা যাচ্ছে?
জি স্যার, দেখা যাচ্ছে স্যার।
হ্যাঁ, দেখা যাচ্ছে ফুটবে।
আসসালামু আলাইকুম, ভেরি গুড ইভিনিং। আসলে আজকের ওয়েবিনারে আমার টকটা হলো হ্যামস্ট্রিং টেন্ডন হারভেস্টিং। Basically, hamstring tendon easier to harvest comparatively to other tendons like bone patellar tendon, more complicated, more chance of complications, but it is comparatively easier to harvest. And there is very low donor side morbidity in case of hamstring tendon. And you know, there are some intrinsic complication of bone patellar tendon like donor side morbidity, anterior knee pain. These are usually absent. Even large skin incision that is made in the harvesting the patellar tendon, it is absent here. It is a smaller cosmetic incision, and the strength of the hamstring is comparable to the native ACL. You know, all the native ACL strength is about 1700 Newton, but it is around 41 to 42,000 Newton in case of hamstring tendon. That reason, it is very much popular, and unless some special indication of the quadriceps or the bone patellar bone tendon like in the sporty girls, everybody usually choose the hamstring tendon. But the procedure is somehow or sometimes bit difficult for the learners, and especially when there is a identification of the tendon, sometimes become difficult for the learners, and sometimes there is difficulty in harvesting. That means it become prematurely cut down, so there's failure of the procedure. And sometimes there is structural injury like the medial collateral ligament and others. So my target of this today's talk how to overcome these technical problems and avoid the inherent complications that may happen during the harvesting of the semitendinosus tendon. So before going to talk about my procedure, I'd like to say something about the anatomy. We know all the insertion of the three tendons, semitendinosus, gracilis, and sartorius in the base and serenus. And usually, usually sartorius tendon with the deep fascia forms a tent over the semitendinosus and gracilis tendons. So this is the semitendinosus and gracilis tendon. And important issue is that there are many, sometimes ranging from 1 to few vincula, what is shown with the arrow, with the semitendinosus especially, that sometimes poses the threat for harvesting, as because if you don't clear this vincula, there may be premature rupture or premature cut down of the tendon, resulting failure to harvest the tendon. And you see here the exposed semitendinosus tendon in the after the incising the screen. And another important structure, the inferior branch of the saphenous nerve, which runs posterior to anteriorly, just above the vertical incision if you make it. So sometimes this structure become injured, and if you do not aware about it, frequently it may injure the nerve, and that resulting area of anesthesia. Sometimes patient complains about it, though maximum places this anesthesia usually improves with time. So making incision is important to avoid the nerve injury. Now, if you go to start the procedure, prior to final positioning, the injured knee is examined under anesthesia. That is very important. All arthroscopic procedure must be preceded by examination under anesthesia for the final confirmation of the diagnosis. And for the beginners should mark the area. That is very important. So pre-operatively, before going to start, you should mark the area with the marker pen for the portal, for the patella, this patella tendon and tibial tuberosity. And if you make the incision oblique, you may mark oblique, or you may do vertical incision, whatever you choose. So talking about the incision, so approximately 2 to 3 centimeter in length the incision, it may be vertical and oblique, I had told earlier. And it is the medial, if you make the vertical incision, it should be midway between the tubercle and posterior medial border of the tibia. So this is the typical incision site. And to avoid the nerve injury, you must not extend the incision much higher. If you go higher, there is more chance of injury to the medial branch of the saphenous nerve. So that is another important guideline, that you should not make the incision much higher. You may start from this mid of the tuberosity and below, and length about 2 to 3 centimeters. That we can reduce the chance of the nerve injury, and thus avoiding the complication of anesthesia. So after whatever may be the incision, you have made the incision, then blunt decision of the level of the sartorial fascia. This injury and this incision is made obliquely along the direction of the tendon of the semitendinosus and gracilis. And when you make the incision should be extended using first 2 borders of the incision should be cleared with the help of the hemostat or medium artery. Then the incision is extended using a scissor. So this is the technique I use usually when you see the tendon identification become difficult. When the patient is medium health, you can get, or you can see an elevation. That can give you idea of the tendon. But when the patient is very much obese, excessive fat, or extremely lean and thin patient, then this elevation of the tendon of semiti and gracilis is usually not found. That time, what I usually do, artery is placed there. এই আর্টারিটা উপরের নিচে মুভ করলেই আর্টারির নিচে টেন্ডনটা স্লিপ করে, তখন একটা আইডিয়াটা পাওয়া যায় যে কোন জায়গায় এই টেন্ডনটা আছে। At that place we should place the incision over the semiti and gracilis. So this is the incision we make usually over the semity and gacilly deep fascia. And very important to skeletonize the tendon, as because if you don't skeletonize the tendon properly, it will be difficult to negotiate it. So nice skeletonization an important step of the identity. So here the tendon, the incision mark or incision over the fascia, we use the scissor. We use to extend the incision on of the deep fascia. So both tendons should be identified simultaneously to avoid the confusion. Here we have identified both semitendinosus and gracilis tendon. Usually semitendinosus tendon lies below and the gracilis tendon lies above in position. So important, that another important issue is that you see the tendon is put on traction using the Penrose drain. Usually we use the cut saline set to putting the traction, and during putting the traction you should cut all the vincula available, with especially with the semitendinosus tendon. If you don't clear the vincula or fibrous attachment, when you try to harvest the tendon with the stripper, the tendon will cut at the point of the vincula. So vincula will not cut, but tendon will prematurely be cut down, and the failure of the harvesting of the tendon. So proper identification, proper skeletonization, remove all vincula, usually 1 to 3 vincula, and it extends up to 13 centimeter of the length of the tendon, usually. And when the all vincula are removed, then you can, excursion of the tendon become very easier. Till it is difficult, you should search for the further vincula and identify it and cut it. And there is different techniques. Somebody put the tendon, cut it, and they put the suture. The modified Krakow suture is put there, and tendon is put under traction. Then when identified and put under tension, the stripper usually proceeded with the corkscrew manner and not putting the excess pressure, as because when there is a much, you feel much resistance, you should stop and think there is something wrong and you should clear it more. So gradually and steadily press it, your stripper, pull the tendon and make corkscrew movement so that the tendon easily comes out. So when you have harvested both the tendons, deep to the tendon, there is a very much shiny structure. This shiny structure is the medial collateral ligament. And very important not to injure this medial collateral ligament, as because this medial collateral ligament is very much important for the medial stability of the knee. So important issue is that when you hook with your hemostat or the other instrument, the MCL does not, what I say, it doesn't have any excursion. It is very tough. So don't cut this tough structure. That is, harvest tendon and do not injure the medial collateral ligament. And the wound usually caused by appropriate suture materials. So at the last, what I'll say that properly identification the tendon first. That is very important. Skeletonize whole tendon and remove all the vincula so that the premature cut down can be prevented, and avoid injury to the medial collateral ligament during the harvesting the semitendinosus tendon. Thank you very much for patience hearing.
Thank you, Dr. Farid, for wonderful presentation for the first step of ACL reconstruction or other ligament reconstruction is a harvesting of tendon, and that is the hemistine. Nice presentation. Thank you, Dr. Puri. Yes. Now I send to our panelists regarding the question and evaluation. Please take the program on. Dr. Hassan Masood and Dr. Parvez Hassan. Sir is here. Kabi sir, can you hear me?
Audible?
Sir, Kaji sir, can you hear me? Yes, yes, sir. Yes, you and Dr. Hassan Masood and Dr. Parvez Hassan. And evaluate and
Dr. Jahim,
Okay,
you have it? Okay.
yes.
Now, the first question was to Dr. Javed
Yes.
Jahangir Tuhin. Why
Okay.
tourniquet is not used nowadays in knee arthroscopic surgery? Dr.
Thank you,
Javed
sir.
Jahangir Tuhin.
Thank you for a very nice question. And tourniquet is usually used in knee surgery. Not only arthroscope, many knee procedure we done under arthroscopic to increase the visibility, But tourniquet has some limitation. You cannot put a tourniquet longer time. For knee surgery, you will only put highest time is recommended is 2 hours. Sometimes you want to use it, you have to deflate for a 15 minutes or more, then you reapply it. But this also have some disadvantage. If you deflate it for one time, there is a completely red out and you have to wait more than 10 to 13 minutes to clear up the joint. And it was shown that in other parts of the body, the shoulder surgery, in elbow and other parts, they no need of tourniquet basically. In commonly done shoulder surgery, ultimately, we can do it very nicely. So it is more experience. It was shown that if tourniquet is not used, it will not, and not a problem in also in knee surgery. You have to just keeping the knee distended and maintain the distension pressure within 60 to 80 millimeter of mercury. For 10 to 15 minutes, you have facing some problem. After 15 minutes, the joint is clear and more you will be comfortable with the viewing the intraarticular structure. So more and more arthroscopic surgeon also doing knee arthroscopy without tourniquet.
Okay, thank you, Dr. Javed Jahangir Tuhin. And another reason for not using the tourniquet during meniscus surgery, because you have to see the punctate bleeding during the repair of the meniscus surgery, whether there is punctate bleeding or not. So I request Kavi sir, whether any adding to this question, sir. This is from Dr. Roni Kader, Colonel Roni Kader. This question, why tourniquet is not used nowadays in arthroscopic surgery? Any other addition, sir?
Visualization is very important. If you fail to see what you are doing, then
Yes,
you are losing time. You are like Dr. Javed said that you may have to wait 10 minutes, 15 minutes, half an hour to clear up. So this is also bothersome. I will not do my knee surgery without giving a tourniquet. I want to have a very clear field. Yes, the issue of the time is there. You have to finish your surgery by 1.5 hours, 2 hours. You must be confident to finish your surgery by 1.5 hours, and you want to also see what you are doing. That means I'm in favor of using a tourniquet.
Tourniquet, sir.
Okay, sir. Professor Parvez Hassan, anything?
Yes, I had some comments on this. Actually, there are some surgeons who does not use tourniquet, but most of the surgeons in arthroscopy is doing with tourniquet. But it should be in limited time. But it is not. It is not true that most of the surgeons nowadays not use tourniquet. They are using other tourniquet, not tourniquet used in our country. This is they are using that is machinery tourniquet. But without tourniquet, it is difficult to visible in arthroscopy. That is my comments.
Can I
doc-
share? Can I share?
Yes, please.
Yes, yes. Now it is. I agree with Dr. Kadir because a limited now our arthroscopic need like meniscus resection, flap tear resection or tear as a day case surgery. In this case, they use just portal inject with noradrenaline or epinephrine mix local anesthesia at the portal. So there is no bleeding because source of bleeding is the portal side, but inside there is no chance of bleeding. I I think so.
Okay, thank you. And the second question is again to Dr. Javed Jahangir Tuhin from Dr. Ashikur Rahman. What are the advantages of triangulation technique? Dr.
You
Javed
must
Jahangir.
learn. Thank you, sir. Thank you. Very pertinent question. Triangulation technique is a very important and essential part of learning arthroscopy. Triangulation means viewing or coming together within the field of view two or more instruments. In intra-articular surgery with arthroscope, you must have to see where your instrument, what you are doing. If you put in a bite with punch, of not seeing, it will injure the cartilage or any intra-articular structure like meniscus and ACL or PCL. So you have to precise, and there is a very narrow zone here. So you have to precise and you have to know the triangulation. Until you learn triangulation, you can do a arthroscopic surgery. So triangulation must needed for arthroscopic surgery. Thank you.
Thank you. Professor Kavisar is doing arthroscopy from ancient times, sir. You are our teacher. We learn many things from you. And when you are doing the arthroscopic surgery, we just learned that there is a subject called arthroscopic surgery. So I would like to request you to add something in triangulation technique, sir.
Arthroscopy learning is a longer period of learning than is other surgery. You will
Yes,
find
sir.
out those of us who are doing it and those of us we are trying to learn it, you will find out that it has got a long learning curve.
Yes, sir.
Among the long learning curve, let's say you can divide it into three parts. Number one is just standing behind the surgeon
Sir.
and try to understand what the surgeon is seeing or doing. This is number one. In other words, try to recognize these structures on the monitor. You are looking at the monitor. The surgeon is doing all the work. This is step number one. Step number two, you yourself make portal and you put the telescope inside, arthroscope inside, and you move around the knee. And you can see all these structures one by one. This is step number two. And step number three is triangulation. When you can put your arthroscope and your another instrument inside, and you can work with both, that is when it is called triangulation. Triangulation is the most important and final part of your learning. So if you can triangulate, then you can do your surgery.
Yes, sir. Thank you, sir. Thank you for very informative discussion. And now another question: is there any role of PRP in cartilage damage? First, I would like to answer from Professor Parvez Hassan. Then I will ask it to Dr. Jahangir Hussain. So, Professor Parvez Hassan, any comment? Is there any role of PRP in cartilage damage? So, what is your perspective?
Actually, PRP is used in osteoarthritis. That is very well known. And PRP, there are some generation of PRP. There's the first generation PRP and second generation PRP. And PRP is used as an orthobiologics. That means it uses during articular cartilage damage in osteoarthritis. That we know. But I think there is other uses of PRP in knee also. I think in cartilage damage, PRP, second generation PRP has a role that I can say.
Okay. Dr. G.M. Jahangir Hussain, your comment,
Thank
please.
you. It is nowadays it is a burning issue, PRP. Actually, in case of articular cartilage damage or osteoarthritis or whatever it is, there is this PRP act as a marrow augmentation. When there is associated puncture, micropuncture or nano fracture, that is introduction of PRP, it acts as an augmentation for the fibrocartilage to healing the defect. So I think this is the information which is written in the ANA, that is North American Arthroscopic Association rules. That is PRP may also act as an augmentation of fibrocartilage to repair the healing of the chondral defect.
Okay, thank you.
Can I ask one question?
Yes, sir.
আমি একটা প্রশ্ন করতে যাচ্ছি এটা ব্যাপারে। হ্যাঁ, when we are giving PRP, we are giving it like an injection, like a steroid যেভাবে দিই সেভাবেই তো।
ওইভাবে
দাও স্যার। PRP ডিফেক্টে দিতে হবে, ইনজেকশনের মতই বলছে স্যার, ক্যানুলা দিয়ে দেয় যারা অরিজিনাল যে ক্যানুলা, বাট in our perspective they introduce only for syringe ইত্যাদি। PRP
আমি ডিফেক্টটা আমি বুঝবো কি করে?
ডিফেক্টটা স্যার আপনি আর্থ্রোস্কোপিক্যালি দেখতে হবে। এটা যারা আর্থ্রোস্কোপিক সার্জনরা যেটা বলছে বা বইতে বলা আছে লিটারেচার, যে ওখানে ডিফেক্টে কত মাইক্রো পাংচার করা হয়েছে, তারপরে ওখানে পিআরপি দেওয়ার পরও ফিব্রিন ক্লট অর যেটা পরসিন কোলাজেন মেমব্রেন দিয়ে অগমেন্টেশন করে স্যান্ডউইচ টেকনিকে দিচ্ছে, তাহলে বলছে যে রেজাল্ট ভালো হচ্ছে। এগুলা রিসেন্ট লিটারেচারে বলা হচ্ছে অনলি পিআরপি অ্যালোন শুধু অনলি অগমেন্ট করবে।
আপনি ওখানে দিয়ে আসলেন, পিআরপি ম্যাটেরিয়ালটা দিয়ে আসলেন, ওটা ওই জায়গায় থাকবে কেন? হ্যাঁ, সাইনোভিয়াল ফ্লুইড আছে।
না স্যার, সাইনোভিয়াল তো ফ্লুইড লিমিটেড জয়েন্টের মধ্যে, আপনি ওই যে স্যালাইন দিয়ে প্রথম আর্থ্রোস্কোপ, এটা ড্রাই আর্থ্রোস্কোপিও করা যেতে পারে, ড্রাই আর্থ্রোস্কোপি করে দিলেন বা পানি দিলেন রিমুভ করে। কিন্তু ওখানে ফিব্রিন ক্লট যেটা কমার্শিয়ালি অ্যাভেলেবল, যে ফিব্রিন মেমব্রেন পাওয়া যায় বা পোর্সিলিন মেমব্রেন বা ফিব্রিন গ্লু, এটা অ্যাভেলেবল স্যার কমার্শিয়ালি, সেই ফিব্রিন গ্লু দিয়ে উপরে দিলে ওটা অ্যাটাচ হয়ে যাবে। ইভেন হয়তো 4 to 6 week non-weight bearing, but range of motion can be start early. এটা ফিব্রিন গ্লু দিয়ে দিতে হবে।
জাহাঙ্গীর ভাই, স্যারের কথায় প্রেক্ষাপটে আমি একটা বলি। স্যার কিন্তু বলতেছে ঠিক আছে, অনেক জার্নালে আসছে যে পিআরপি জাস্ট ফ্লোটস ইন ইওর নি জয়েন্ট উইদিন ইওর সাইনোভিয়াল মেমব্রেন, দেন গেটস অ্যাবজর্বড ইজিলি, সো ইট ডাজন্ট অ্যাকচুয়ালি এফেক্ট ইন দ্য ডিফেক্ট। স্যার যেটা বলতেছে এটা কিন্তু অনেকটা এটাই বলতেছে জার্নালে।
ঠিক আছে, স্যার তো বলছে যে আমাদের দেশে তো অরিজিনাল পিআরপি দেওয়ার মতো হয় না, পরিস্থিতি সেই রকম ক্রিয়েট হয় না, যেটা সায়েন্টিফিক্যালি বাইরে যেটা দিচ্ছেন ওরা লিটারেচার বা এনার সোসাইটি যেটা বলতেছে যেভাবে দেওয়ার জন্য।
ডক্টর জাহাঙ্গীর, আমি একটু অ্যাড করতে চাই, সেটা হচ্ছে যে পিআরপিটা এখন যেগুলো আসতেছে আর্টিকেল, তাদের মধ্যে বলতেছে যে পিআরপিটা নাকি অত এফেক্টিভ না, তার থেকে যে স্টেম সেল এফেক্টিভ বেশি। কারণ স্টেম সেল হচ্ছে যে আপনার ওই যেটা বললেন যে ড্রাই আর্থ্রোস্কোপি, অর্থাৎ ওখানে যাতে কোনো পানি না থাকে, তারপরে আমরা স্টেম সেল দিয়ে আসলাম এবং স্টেম সেলের অ্যামাউন্টটা তো বেশি, ওটা পুরো জয়েন্টেই থাকে এবং আস্তে আস্তে ওটা এফেক্ট করে। এইটা এখনকার জার্নালে বলতেছে, মানে পিআরপির কথাটা না এখন আস্তে আস্তে বোধহয় কমে যাইতেছে। এবং স্যারের সঙ্গে আমি একমত যে ওইখানে তো পিআরপিটা থাকবে না এবং সাইনোভিয়াল ইয়াতে অ্যাবজর্ব হয়ে যাবে এবং হয়তো অতটা এফেক্টিভ হবে না। এবং জার্নালগুলো তো আসতেছে যে এখন পিআরপিটা অত অ্যাক্টিভ মানে এফেক্টিভ না, কিন্তু স্টেম সেলের কথা বলতেছে, দুইটার মধ্যে যেটা স্টেম সেলটা বেশি ইফেক্টিভ, এটা বলতেছে।
স্যার, ক্যান আই এড সামথিং স্যার?
ইয়েস।
পিআরপি আর স্টেম সেল দুইটাই স্যার অর্থোবায়োলজি, দুইটাই এখনো ইভলিউশন পর্যায়ে আছে। ইভলিউশন পর্যায়ে আছে, আমরা এখনো ডেফিনিটিভ যে এটা একেবারেই মানে ইন্ডিকেটেড বলা যাবে না স্যার,
বলা যাবে না।
দুইটারই কিন্তু প্রমিজিং রেজাল্ট আছে, জাহাঙ্গীর ভাই যেটা বলতেছে, আপনি যখন স্যার কার্টিলেজ ডিফেক্টে দিবেন পিআরপির কিন্তু এলোন কিন্তু খুব কম। আমরা কিন্তু অ্যাডজাংক্ট হিসাবে যেমন মিনিস্কাল রিপেয়ারে দিচ্ছি, আবার কন্ড্রাল ড্যামেজে যখন আমরা দিচ্ছি তখন কিন্তু কনফাইন করে আর্টিকুলার কার্টিলেজ যে ডিফেক্টটা ওই জায়গাটা কিন্তু সিল করে দেওয়া হচ্ছে, ওই জায়গাটা থেকে কিন্তু কোনোভাবেই পিআরপিটা বা যে জিনিসগুলো আপনি দিচ্ছেন এটা কিন্তু সরে যাওয়ার কোনো সুযোগ নেই, কারণ ফিব্রিন মেমব্রেন দিয়ে আপনি কিন্তু এটাকে সিল করে রাখতেছেন। তো সেক্ষেত্রে দেয়ার মাইট বি ইফেক্ট, তবে এটা এখনো যে কনক্লুশন আসার মতো কোনো সময় আসে না।
আসলে আসেনি। যে অর্থোবায়োলজির তো অনেক ধরনের আছে, পিআরপি, স্টেম সেল, এবং আরো রিসার্চ করতেছে, এমনকি ওই কনমেড লিনফ্যাটিকও একটা অর্থোবায়োলজিস্ট আনছে, যে এটা হলো যে ওই থার্ড জেনারেশন পিআরপির মতো। তো যাই হোক, এখন স্টাডি হচ্ছে, আমাদের মানে ইয়েগুলি আমরা জানাচ্ছি। তো এরপরে নেক্সট কোশ্চেন হচ্ছে, ইন টাইপ 4 আর্টিকুলার কার্টিলেজ ড্যামেজ, if we treat the patient with microfracture technique, articular cartilage is replaced by fibrocartilage, will it be helpful to the patient, and will the patient will live in a pain-free life? So what is your comment, Dr. G.M. Jahangir?
Thank you. So this is very valid question. If we think a adult patient, it is
And
cartilage damage.
Type 4 articular
cartilage damage, middle age or adult old patient due to the osteoarthritis or other region traumatic type 4 cartilage damage. In this situation, a microfracture induced fibrocartilage, this will relieve pain up to 80 to 85% for up to 5 to 7 years. This literature says. But in case of active adult, but it will not improve. It is daily activity, sportsman, but the fourth type of articular cartilage damage, only microfracture will not well-being the patient.
Any comment from Professor Parvez Hassan?
Yes. I want to ask one question about G.M. Jahangir. In which age it is preferred to give your regime, that is the articular cartilage replacement regime?
Yes, so the articular cartilage, but there are several varieties in Western countries. But in our scenario, we can do only micropuncture and mosaic plastic can do. And also in recently, we can do micropuncture as well as thermal chondroplasty, as a radio frequency ablation. So we cannot think other thing in our perspective. We can do only micropuncture because in adult it will relieve pain up to 80 to 85%, and it is passing about 3 to 5 years in literature. But in case of adult, young adult but active person, sportsman, contact sports, more demand, they cannot be relieved with the only micropuncture alone. She should be other procedure, can be mosaic plasty as well as ACI, autogenous chondrocyte implantation. This is very popular procedure in Western country now.
So if a patient comes like about 50-55 years with osteoarthritis mostly, do you advocate your treatment?
No, you can assess the axial alignment. Either he or she has been suffering from axial malalignment, varus, valgus, or patellofemoral, tibiofemoral arthritis. So treat first with associated other ligamentous instability. All treat ligamentous and axial alignment, then you do the treatment of osteochondral defect. Otherwise, osteochondral defect will not work properly and cannot give the well-being to the patient.
Yes, exactly. If there is malalignment, so you have to correct the malalignment either by osteotomy or other procedures, and then the microfracture will act. So, Professor Kavi sir, do you have any comments, sir?
I think there is about doing these procedures, you have to be careful about selecting your patients. A radiological grading, Kelly-Crane 1, 2, 3, 4, is obviously important, because you won't do your subchondral fractures or chondroplasties in stage 3 or stage 4. You will think about it in stage 1, which is similar to the arthroscopic outbridging classification. You can do it in outbreed classification 2, 3, like that. Not 1, 2 or 3,
Yes,
but
sir.
not in advanced stages. Advanced stages are for outright arthroplasty.
Okay.
Thank you.
Thank you, sir. So another question for Dr. Farid from Lieutenant Colonel Abdul Kader. I saw different type of incision like vertical, oblique, and horizontal. What you suggest, Dr. M. Fariduddin?
Thank you, Dr. Kader. Basically, incision is of a personal choice. There is no big variation of harvesting. It also depends on the cell expertise. Say I am expert in vertical incision. If you say to make me oblique incision, it may cause difficulty for me. So only and the issue is that in vertical incision, one must be careful not to injure the nerve. Otherwise, there is nothing difficulty or nothing problem of making any kind of incision, either vertical, oblique, or horizontal. What is your choice? You can make it.
Okay, thank you, Dr.
Can
Fariduddin.
I share with something?
Yes, please, please.
Thank you for it, for your it's a good explanation. As because ascending branch of Chapman's nerve, it runs over the obliquely according to the direction of sartorius passion. So I can, during the harvesting the tendon and during the incision is made, I more flex the knee, then will saphenous nerve go to more back. This
More
I posteriorly. So I think this will help to not disturb the ascending branch of saphenous.
Yeah, Dr. Bakibullah, is there any role of postoperative intraarticular tranexamic acid for stopping postoperative intraarticular bleeding? Dr.
Thank
Bakibullah.
you. Thank you for your question. I think there is no role of transgenic acid because in arthroscopy in knee, there are no place for bleeding. All the tunnels are blocked by ligaments. New ligament that we place in the tunnel that will prevent the bleeding. In fact, we never chose to place any join also. So I think no need to use any connectivity.
Can I add something?
Yes, please.
Yes, actually, we used adrenaline whenever we want to stop bleeding or reduce bleeding within the joint, and we want better visualization. We use adrenaline. I don't have any literature, have any heard about the injecting tranexamic acid.
Oh.
Sir, Kavi sir, can you say something?
Professor
can I
Kavi sir? Yes,
No,
sir.
no, I'm sorry, I do not have any experience
Sir,
about
can
it.
I have a
Yes, Dr. Javed Jahangir, because one of the participants asked this question.
Yes,
So
sir.
please
So
satisfy him.
my input is my input is tranexamic acid is more and more arthroscopic arthroplastic surgery we use tranexamic acid at the beginning of incision. In more complicated surgery you use tranexamic acid for hemorrhage, decrease hemorrhage in arthroplasty particularly. But for arthroscopic surgery and for postoperative bleeding control, there is no rule, I think, and no literature is suggesting like this. If you want to reduce bleeding, you can add noradrenaline or adrenaline with your irrigation fluid. It is say it increase visibility and clear clots.
Okay. So any question from the participants? Any question? I'm inviting any questions.
আমার একটা কোশ্চেন আছে প্যানেল অফ এক্সপার্ট সবার কাছে যে কেউ আনসার করতে পারি আমরা, সেটা হচ্ছে যে আমাদের রিঅ্যালাইনমেন্ট প্রসিজিওরটা বিশেষ করে যেটা কার্টিলেজ ড্যামেজের ক্ষেত্রে আমরা এইচটিওর রোলটা বলে থাকি। এইচটিওর ইন্ডিকেশনটা কি, কোন সময় আমরা এইচটিও করলে পেশেন্ট বেনিফিটেড হবে?
GM Jahangir, Dr. GM Jahangir.
Yes, it is very important question. Very important question. Realignment osteotomy, either varus valgus, proximal tibial for varus osteotomy and distal valgus for distal femur osteotomy. When axial alignment is due to the conic ligamental instability and adequate articular by MRI or arthroscopy, you see there is articular cartilage no more damage, and it is young up to 45-50 years the patient. Then we do the osteotomy. This will lead to loading to unloading surface and equal distribution of the weight bearing area. In this situation, patient will get benefits from the osteotomy, provided interarticular interarticular stability is maintained. Any more can share?
Any more? Professor Kavi sir, anything?
No, I'm sorry. I do not understand this thing properly.
Masood, you can say, because you had done a lot of high tibial osteotomy and you have a course experience in India also. You can say something about high tibial osteotomy.
না, আমি এটার মধ্যে কোশ্চেনটা ওপেন রাখছি প্যানেল অফ এক্সপার্ট কেউ বলেন একটু।
জি, সেটা হচ্ছে যে হাই টিবিয়াল অস্টিওটমি দেখতে হবে যে আমাদের যে নরমাল ভ্যালাস বা ভালগাস অ্যালাইনমেন্ট সেটা আছে কিনা, এবং সেটার যে নরমাল রেঞ্জ সেইটার যদি উপরে হয় ফিমেল বা মেইলের ক্ষেত্রে, এবং এইজটা ডক্টর জাহাঙ্গীর বলছেন ঠিক যে আমরা 50-55 পর্যন্ত, এরপরে হলে কিন্তু হয় না, কারণ অস্টিওপোরোসিস ডেভেলপ করে, তখন ওই লোডিং আবার হয়ে যায়, আনলোডিং এর পরে আস্তে আস্তে লোডিং হয়ে যায়। এই জন্য বলে যে 50-55 এর আগে হলে আমরা হাই টিবিয়াল অস্টিওটমি করতে পারি। এবং হাই টিবিয়াল অস্টিওটমি হলে হয় কি যে যেখানে লোড, ধরেন মিডিয়াল কম্পার্টমেন্ট অস্টিওআর্থ্রাইটিস যদি থাকে এবং সেটা গ্রেড 1 বা গ্রেড 2 হয়, গ্রেড 3 তে কোনো লাভ হয় না। গ্রেড 1 গ্রেড 2 ক্ষেত্রে বলে যে তখন অস্টিওটমি করলে লোড যেটা লোডটা তখন আনলোডিং হয়, এবং তখন হচ্ছে যদি আমরা মাইক্রো ফ্র্যাকচার করি অথবা যেটা বাইরে করে যে অটোলগাস কন্ড্রোসাইট ইমপ্ল্যান্টেশন এসসিআই, সেই ক্ষেত্রেও এটা তখন এফেক্টিভ হয়। এই জন্য কথা হচ্ছে আমরা একটা ওই যে স্ক্যানোগ্রাম, এটা ডক্টর জি এম জাহাঙ্গীর খুব ভালোভাবে বুঝাইছে, যে স্ক্যানোগ্রাম করে আমরা দেখে নিব যে হিপ এবং নিয়ের অ্যাঙ্গেলটা, এবং নিয়ে কোনো ভ্যারাস বা ভালগাস আছে কিনা, সেটা নর্মাল রেঞ্জের বাইরে কিনা। যদি নর্মাল রেঞ্জের বাইরে থাকে সেই ক্ষেত্রে কিন্তু অবশ্যই আমরা যদি কোনো প্রসিডিওর করতে চাই, মাইক্রো ফ্র্যাকচার বা অটোলোগাস কন্ড্রোসাইট ইমপ্ল্যান্টেশন, এবং শুধু তাই না, আমরা যে পিআরপির কথা বললাম, স্টেম সেলের কথা বললাম, এইসব ক্ষেত্রেও যদি অ্যালাইনমেন্ট ঠিক না থাকে তাহলে কিন্তু অবশ্যই অস্টিওটমি করতে হবে। অস্টিওটমি না করলে কিন্তু রেজাল্ট, আলটিমেট রেজাল্ট ভালো আসবে না, সেই জন্য অস্টিওটমি করতে হবে। এবং যদিও আমি অস্টিওটমি করছি ইয়ের জন্য না, মানে এই মানে ডিফর্মিটির জন্য অস্টিওটমি করছি, কিন্তু আসলে কার্টিলেজ ইনজুরির জন্য অস্টিওটমি করি নাই। কিন্তু আমি যেসব ডিফর্মিটির জন্য ইয়ে করছি, এবং আগে একটু ওভার এনথুসিয়াস্টিক ছিলাম, তো আমি দেখা গেছে যে 60 ইয়ার্সেও অস্টিওটমি করে দিছি, কিন্তু উগলি রেজাল্ট ভালো না। ম্যাক্সিমাম 55 আমার যেটা মনে হয়েছে, এবং আমি লিটারেচারেও দেখছি যে 55 ইয়ার্স পর্যন্ত অস্টিওটমি করা যায়, ওর পরে অস্টিওটমি করে কোনো লাভ হয় না। থ্যাংক ইউ।
আমি যদি কে না থাকে, আমার বাকি বিলের কাছে একটা প্রশ্ন আছে, করতে পারবো প্রশ্নটা?
জি জি, শিওর স্যার।
হ্যাঁ, এই যে আপনি যখন দেখেছেন যে পোস্টেরিয়র ব্লো আউট হয়ে যাওয়ার পসিবিলিটি থাকে ইফ অ্যানাটমিক অ্যাক্সেসরি ইন্টারমিডিয়েট পোর্টাল দিয়ে অ্যানাটমিক ফিমোরাল টানেল করেন, যখন আপনি যখন করতে যাই অ্যাক্সিডেন্টালি ব্লো আউট হতে পারে, সেটার জন্য কি আগে আপনি কি কি প্রিকশন নিয়ে রাখেন? সেটা আপনি যখন আপনার সার্জারি গুলো করেন কি কি প্রিকশন নেন? যদি অ্যাক্সিডেন্ট ব্লো আউট হতে পারে, এমন যে কোনো সার্জনের কাছে হতে পারে, সেকে কি কি মেজার আপনি করে রাখেন?
Thank you, sir, for your nice question. If is there any accidental this type of occurrence happen, তার জন্য আমাদেরকে আগে থেকেই একটু মেন্টালি প্রিপেয়ার্ড হয়ে থাকতে হবে যে if we chose the fixation by screw, then we should have another option like substantially fixation. We can fix the ligament by endo button, or even by any titanium button from lateral side, and that will make us free from this trouble. And another option there may be, if we face this type of problem, we can change our direction, and we can make another tunnel to save our patient and to save myself also. Thank you, sir.
ঠিক আছে, fine. You can use end of water. You may introduce retrograde screw or you make a vertical tunnel. Thank you. Thank you.
ডক্টর জি এম জাহাঙ্গীর এই কোশ্চেন করার জন্য আমি আপনাকে অনেক ধন্যবাদ দেই, কারণ আসলে আমাদের ম্যাক্সিমাম অর্থোপেডিক সার্জারি কিন্তু ব্লো আউট হয়, এবং যারা এক্সট্রিমলি এফিশিয়েন্ট তাদের কথা আলাদা, আর যারা একটু কম কেস করে তাদের কথাও আলাদা, কিন্তু যারা বেশি কেস করে এবং অত এক্সট্রিমলি এফিশিয়েন্ট না তাদের কিন্তু এই ব্লো আউট হতেই পারে। এবং আমি জানি আপনারও হয়েছিল, আমারও হয়েছিল, আমরা শেয়ার করছি, হ্যাঁ, ডক্টর পারভেজ হাসানেরও হয়েছিল, যাই হোক মানে হতে পারে। তো আমি একটু ফরিদকে বলি এই সম্বন্ধে, ফরিদের অভিজ্ঞতা কি, যে ব্লো আউটের কোনো কেস পাইছিলেন কিনা, বা আল্লাহ আপনাকে আল্লাহওয়ালা দেখে আপনাকে গ্রহণ করছিল কিনা?
স্যার, আই এম সো ফরচুনেট,
হ্যাঁ,
আমার হয় নাই স্যার আল্লাহর রহমতে এই পর্যন্ত।
আচ্ছা আচ্ছা, থ্যাংক ইউ, খুব ভালো যে ব্লো আউট কিন্তু একটা।
জি স্যার,
হ্যাঁ বলে,
যে কোনো সময়ই হতে পারে স্যার,
যে কোনো সময় হতে পারে,
হয়ে যেতে পারে স্যার, তো আল্লাহর রহমতে হয় নাই স্যার।
আচ্ছা,
স্যার আমরা সমস্যার সময়ের দিকে
This is not only the tunnel process.
বাকতুল্লাহ, হ্যাঁ বলবেন।
I want to add something only. The bone quality. If the bone quality is very poor, if the bone quality is very poor, then maybe the posterior blowout may be there. I have experienced one case only, the posterior blowout. At that time, I fixed it by the end of it.
আমরাও তাই করছি, যে ওই এন্ডোবাটন দিয়ে ফিক্স করছি, এবং একটা ভালো কথা বলছে যে বোন কোয়ালিটি। আর আরেকটা কথা হচ্ছে কি, অনেক সময় ভিজুয়ালাইজেশন পুয়ার হলো, ওই যে যেটা বললেন যে 2 মিলিমিটার মার্জিন, কারণ আমরা তো ফিমোরাল যেটা করি, আমরা টানেলটা আমরা অনেক সময় আমরা ওই জিগ দিয়ে করি না, ফিমোরাল জিগ দিয়ে করি না, আমরা ইয়ে করি, অ্যাপ্রিসিয়েশনে করি। তো এই জন্যই একটা পসিবিলিটি থাকে, সেই জন্যই সাবধান হওয়া ভালো। এবং এই জন্য ডক্টর জি এম জাহাঙ্গীর এরকম কোশ্চেন অ্যারেঞ্জ করার জন্য খুবই ভালো। স্যার, আমি একটু আবি স্যারকে বলবো যে কোনো টিপস এন্ড ট্রিক্স দিবেন কিনা স্যার, কারণ আপনার অনেক দিনের অভিজ্ঞতা, এবং এগুলি অভিজ্ঞতা শেয়ার করার জন্যই স্যার এই ধরনের ওয়েবিনার। স্যার
টিপস ব্লো আউটের এটাই আর কি, ওই ফিমোরাল টানার করার সময় আপনার ফ্রি হ্যান্ড করতেছেন, আপনি অ্যাপ্রিহেনশন যে হ্যাঁ আই উইল নট গো টু পোস্টেরিয়রলি, এটাই বোধহয় একমাত্র সেফটি। ডোন্ট গো টু মাচ অ্যালাইনমেন্ট, আপনারটা আপনার ফিমোরাল শ্যাফটের লাইনটা কোথায়, কন্ডাইলটা কোথায়, আর আপনি কোন দিকে ইয়ে করছেন, প্রসিড করতেছেন।
স্যার এক্স্যাক্টলি,
দিস ইজ দি অনলি সেফটি।
ডক্টর ফরিদ স্যার, আচ্ছা, অনেক সময় যে ধরেন কথার কথা এরকম লিটারেচারেও আসছে, সেই জন্য আমার যদি হয় নাই, কিন্তু যে কোনো সময় হতে পারে। স্যার থ্যাংক ইউ স্যার। সেটা হচ্ছে যে ডক্টর ফরিদ, যে ইয়ের সময় আমাদের করার সময় হ্যামস্ট্রিং টেন্ডন গ্রাফট তোলার সময় হঠাৎ করে ইয়েটা টেন্ডনটা পড়ে গেল মাটিতে, তো এই ক্ষেত্রে কি করা যায় ফরিদ? আমি আপনার লিটারেচারের কথা বলবো পরে, কিন্তু আমাদের তো যে কোনো সময় হতে পারে, হয় নাই তাই বলে যে হবে না এরকম না, কারণ আমি অনেক সময় যে একবার পঙ্গুতে কেস করতে করতে ব্রাদার ফেলাই দিছে, ওই গালিপটের সব বোন গ্রাফট নিচে ফেলাই দিছে। তো যাই হোক, এরকম তো টেন্ডনের ক্ষেত্রে হতে পারে, তো সে ক্ষেত্রে কি আপনি হলে কি করতেন?
স্যার, আমার পার্সোনাল যেটা মতামত স্যার, আমি লিটারেচারের খবরটা তো জানি না স্যার, তাহলে যে মানে পড়ে গেলে এই গ্রাফটা ইউজ না করাটাই বেটার স্যার। দরকার হলে উল্টা পা থেকে একটা টেন্ডন নিয়ে নেওয়া যেতে পারে স্যার, আমার পার্সোনাল অপিনিয়ন স্যার।
এক্স্যাক্টলি, আসলে নিজের ঘুম হারাম করার চাইতে একটা অন্য 2-1 দিন একটু বা 1 সপ্তাহ 2 সপ্তাহ ঘুম হারামের চাইতে একটু অন্য গ্রাফ নেওয়াই ভালো। তবে লিটারেচারে যে আসছে সেটা হচ্ছে যে এই গ্রাফটা কেউ যদি মানে সঙ্গে সঙ্গে পড়ে যাওয়ার পরপরই আপনি ডিটেক্ট করতে পারেন যে গ্রাফটা পড়ে গেছে, সেই ক্ষেত্রে আপনি করতে পারেন যে ভ্যানকোমাইসিন ইমপ্রেগনেটেড রেখে পরে গ্রাফটা ইউজ করা যায়, যে তারা দেখাইছে যে কোনো ইনফেকশন হয় নাই। কিন্তু কথা হলো এটা আসলে একটা টেনশনে পড়ে যাওয়া, যে তাই না? তো এখন যাই হোক, আমরা সবই জেনে রাখি, তাহলে হয়তো আমাদের সমস্যার সমাধান।
Can I have a WhatsApp?
Yes.
Just এই কোয়েশ্চেনটাই পিকেসির প্রোগ্রামে করা হয়েছিল কোনো একটা সময়ে, এই কোয়েশ্চেনটাই পড়ে গেলে কি করা যায়। তা স্যার যেটা বলছেন যে এটার সাথে সাথে স্যালাইন দিয়ে ভালো করে ভিগোরাস ওয়াশ দিয়ে ভ্যানকোমাইসিন সক করে, ইভেন তারা কিছু টক আসছে যে ইউ ক্যান ডু ইট উইথ অটোক্লেভ, You can
autoclave,
autoclave it.
okay, oh, okay.
You can autoclave it. Autoclave করে আবার আপনি ইউজ করতে পারেন।
ইউজ করতে পারি। আচ্ছা আচ্ছা, থ্যাংক ইউ ফর ইনফরমেশন।
স্যার আমার একটা কোশ্চেন ছিল স্যার, বলবো স্যার?
হ্যাঁ,
ক্যান আই আস্ক আ কোশ্চেন?
ইয়েস,
তুহিন
স্যার আমার একটা কোশ্চেন ছিল স্যার।
আচ্ছা
কে কাদের করে
স্যার স্যার আমি একটা প্রবলেমে পড়ি প্রায়ই স্যার, যেটা হলো যে যদি বোর হরিজন্টাল এন্ড পোস্টেরিয়র ফিমোরাল টানেল করি, যখন গ্রাফট স্যার আমি লাগাইতে যাই গ্রাফট আমার ঠিক মতো যায় না, তাহলে আমি এটা কিভাবে ওভারকাম করতে পারি স্যার? গ্রাফটটা ফিমোরাল টানেলে পাস করা যায়।
আমি প্রথম বলি যে আপনি ফিমোরাল টানেল করছেন, দ্যাট ইজ অ্যানাটমিক, মোর oblique, less oblique and more posterior, proxima and posterior, যেটা more horizontal, এটা হলো যে যেটা আমরা রেগুলার প্রবলেম দেখি যে ফুল করবে, যে গ্রাফটা ফিমোরাল টানে ইথিবন দিয়ে ফুল করে, এটা অ্যাক্সিস মেইনটেইন করতে হবে। আমি দেখছি দিস অ্যাক্সিস যদি মেইনটেইন না হয় তাহলে ফিমোরাল টানে ঢুকে না। যে দিক দিয়ে আমি ঢিল করে, আপনি প্রথমত গাইড ওয়ার দিলেন, তারপর 4.5 or 4 দিয়ে ঢিল করে সুসার ম্যানিপুলেশন করলে, তারপর ডিজাইড লেন্থের 7 or 8 করে। কিন্তু এই জন্য যখন আপনি সুতাটা ফুল করবে, টান দিবেন, তখন অ্যাক্সিস মেইনটেইন করতে হবে, এবং আপনার কেবলটা যে একটু লো ডাউন করে নিতে হবে, যে ওই কেবলটা লো ডাউন করে অ্যাক্সিস মেইনটেইন করে যে টানবে, সে অ্যাক্সিস মেইনটেইন করলে সে গ্রাফ দ্রুত তার ফিমোরাল টানে চলে যাবে। যেটা আমি আমার অভিজ্ঞতা থেকে আমি এটা পেয়েছি। এখন অন্য কিছু শেয়ার করতে
এনিবডি
এটা হয় কি অনেক সময়, আমি একটু বলি মাসুদ ভাই,
বলে
অনেক সময় দেখা যায় গ্রাফ নেওয়ার পরে আমরা যে জেন্টামাইসিন সফট করে রাখি বা ভিজিয়ে রাখি, গ্রাফটা বড় হয়ে যায়। এই ক্ষেত্রে অনেক ক্ষেত্রে দেখা যায় যে এন্ট্রি পয়েন্টটা যদি একটু এক্সট্রা রিম করা হয়, তাহলে ওই জাহাঙ্গীর ভাই যেটা বলছে ইনক্লুডিং দ্য অ্যাক্সেস মেইনটেইন, এন্ট্রি পয়েন্টটা এক্সট্রা রিম করলে ইজিলি চলে যায়, গ্রাফটা ইজিলি নেওয়া যায়। এটা একটা ওয়ে করে দেখতে পারেন। যত সাইজে রিম করতেছেন, 8 দিয়ে মনে করেন রিম করলেন বা 7 দিয়ে, ওই 7 এর মুখটাই আপনি এন্ট্রি পয়েন্টে রেখে দিলে কতক্ষণ এন্ট্রি পয়েন্টটা একটু বড় হয়ে যায়, তখন এন্ট্রিটা ইজি হয়ে যায়। এটা ট্রাই করে দেখতে পারেন।
সামদানি ভাই আমি একটু কোশ্চেন করি, ওই সময় যে স্ক্রু লুজ হয়ে যায় যদি, ওরপরে আপনি এন্ট্রি পয়েন্ট
স্ক্রু তো পারা যায় অ্যাকচুয়ালি ভিতরে থাকবে, আর আপনি তো রিমার সেম রিমার ইউজ করতেছেন, শুধু এন্ট্রি পয়েন্টটা
ওখানে শেভ করে দিলে ভালো।
শেভও করা যায়, হ্যাঁ শেভও করা যায়,
দ্যাট ইজ এটাই আর কি।
আপনার তো গাইডও থাকবে।
ওনার প্রশ্ন ছিল যে মেইন অ্যাক্সেস চেক বরাবর যেভাবে দিস ইজ আমার অভিজ্ঞতা, যে এইটা অ্যাক্সেস হলে বরাবর গ্রাফ দ্রুত ঢুকে যাবে, আর না হলে অ্যাক্সেস মেইনটেইন হবে।
এবং এই জন্য যে অ্যাসিস্ট্যান্ট থাকবে তাকে কিন্তু মানে যখন সুতা পুল করবে বা যখন গাইড ওয়ারটা দিচ্ছে, বলতে হবে যে তুমি একটু দেখো যে ইয়াটা অ্যাক্সিসটা দেখে নাও এখন। Hello.
Actually, if we polish the anterior margin of the tunnel, that will prevent the laceration of the graft, as well as passing of the graft will be easy. You know, femoral tunnel anterior border যেটা আছে এটাকে একটু পলিশ করে নিতে হবে। আর during graft preparation, এটা আমাদের জন্য একটা ইম্পর্টেন্ট বিষয় হচ্ছে যে গ্রাফটের যে femoral end যেটা, সেটা যদি ওই যে আমরা ইউজুয়ালি ট্রাইফোল্ড গ্রাফট করি, তো ট্রাইফোল্ডের যে সিঙ্গেল এন্ড যেটা, সেই এটা ওখানে গিয়ে বাটন ইফেক্ট করে, যার কারণে গ্রাফটা ভিতরের দিকে ঢুকতে চায় না। এই জন্য গ্রাফ প্রিপারেশনের সময় আমাদেরকে মোর আশা করতে হবে যাতে করে গ্রাফের এন্ডটা থাকে ন্যারো, আর অ্যান্টেরিয়র মার্জিন অফ দ্য টানেলকে পলিশ করে নিতে হবে, তাহলে খুব ইজিলি আমরা গ্রাফ পাস করতে পারবো।
এটা আসলে টানেল ডাইলেটর আছে, প্লাস একটু রেস্ট করে নিতে হয়,
রেস্ট করতে হয়।
So, yeah, Dr. Javed Jahangir Tuhin, another question for you from Lieutenant Colonel Abdul Kader. Would you please tell about advantage and disadvantage of different type of irrigation fluid?
So, thank you, sir, for your nice question. There are usually 3 types of saline solution used: lactated ringer solution, normal saline. We commonly use normal saline. Normal, it is said that linear solution is much more physiological. So there is a no problem with intra-articular structure swelling. So the more and more recommendation is using Hartmann solution or liquid linear solution rather than normal saline. But in our day practice, we commonly use normal saline. We do not see any problem. I think if it's your arthroscopic procedure is within 20 minutes, 1 hour and 20 minutes, within around 1 hour, it will cause any problem, I think. If you might use the glycine in case of you want to use the electrocautery intraarticularly, in that case you have to use glycine. Thank you.
And another question what is the diameter of the scope in specific just knee, wrist or elbow surgery? What is the diameter?
Usually for a knee and larger joint surgery, 4 millimeter is the standard diameter. But for smaller joint like elbow, wrist, 1.6, 1.7 and 2.7, this type of arthroscopic diameter is used.
Okay, thank you.
Also finger joints are 0.
Okay. Thank you. And any other questions from participants?
Another question to Zangi, sir.
Yes.
Sir, can you please tell me about the thermal chondroplasty?
Yes.
How it's work and
this
thermal
is,
chondroplasty, how it's work? And
thank you for very interesting and essential question. Radio frequency ablation. Now several commercially available this radio frequency ablator, just like Bafford. This creates that is when there is chondro injury. Just like they create a do not injury the other normal tissue, but they create a seal, the injured cartilage. They create a seal to prevent the further injury. This is the literature or companies says that is debridement as well as thermal chondroplasty. In this way, just more electromagnetics, but we do not go there. Just only conceal the injured cartilage without hampering the normal cartilage. In this way, it acts as a thermochondroplasty.
Yes, thank you. Another question to Dr. Bakibullah about the seeing of the visualization of the residence reads. Is there any tips and tricks? Because there are two reads. One is residence reads, another is bifurcated reads. So, any tips to visualize the residence reads? Dr. Bakibullah.
Please unmute, Bakibullah.
Dr. Bakibullah, please unmute. Dr. Bakibullah, can you hear me?
Sir, Bakibullah sir সম্ভবত কানেকশনটা লস করেছে স্যার একটু।
Oh, আচ্ছা।
Yes, এখন okay.
Yes, এখন আসছে। Dr. Bakibullah, can you hear me?
Yes, sir.
Okay, so is there any tips and tricks to visualize the residence reads? Because it is very important, very much important to place the femoral tunnel perfectly. Residence reads.
Very important thing is two things we should realize. Number one, the good visualization condition, and knee position is very important here. Knee should be flexed more than 90 degrees. It is preferable 120 to 130 degree flexion is very important. If need 120 degree flexion, then residence is almost horizontal to the floor, and no ACL fiber is above the residences. So we should be below the residences, and we should be in 10 o'clock position, not more than 10 o'clock position. If we place our jig, femoral jig in this 10 o'clock position, it will create a more horizontal and more reliable tunnel.
Okay. Thank you, thank you. And Dr. Jahangir or Professor Parvez Hassan, is there any difference or anything to add?
Hello.
Hello, Dr. Jahangir, can you hear me?
একটু আমার স্ক্রিনটা ডিস্টার্ব করতেছে, যাক আমি বলতেছি আমার কেন আমাকে শুনতে পাচ্ছেন?
শুনতে পাচ্ছি।
হ্যাঁ, অ্যাকচুয়ালি until now unless you clear the all native femoral attachment of the ACL, you cannot visualize the biparkate line or resident ridge. Resident ridge is when already Bakibullah said when knee is 120-degree more flexion, then it parallel to the ground. When you clear the whole remnant, then you visualize the resident ridge, and this resident is divided by two anteromedial and posterolateral by the biparkate ridge. So it is sometimes very difficult until unless you clean the or old ACL injury without any soft tissue there.
Okay, thank you. So, hello. So, any question from the participants or panelists?
Conclusion.
Okay. Conclusion. Dr. Professor Parvez Hassan, please conclude.
Thank you, the panelist, Dr. Hassan Masood, Dr. Mohammad, participant, Dr. Baki Billah, Dr. Fariduddin, Dr. Samdani, Dr. Tuhin, and everyone.
Professor Kabisar.
Huh?
Kabisar.
Professor Kabisar, of course, he's our director, and respected man. Everyone participated excellently, and we have enjoyed a lot, and we have definitely improved our every aspect of intellect, and definitely we are improving day by day. And thank you every participant for answering intelligently. Thank you everyone. Thanks Professor Iqbal Kavi for giving their important answers, and thanks everyone. So on behalf of UniHealth and everyone, thanks everyone. Thank you.